Okay. My presentation today about about conductive system basing, step by step how to implant a conductive system lead and pacemaker. So I will let Dr. Fatima to start the presentation. Dr. Fatima.
Actually, Dr. Fatima is with me. Okay.
Hi, everybody. It's a big honor for me to be with this amazing team here for my training here in Egypt, and also to participate in this nice presentation. We have some presentation with Professor Rania. Talk a lot about the anatomy of the conduction system, and that is the important points that we should keep in mind during this procedure of conductive system physiological conductive pacing. So here we see in this photo on the left side with the longitudinal axis, we see the AB node that's in the arterial wall, and the his that penetrate the perimembranous septums. And after that, we have the bifurcation to left bundle and the right bundle. So to understand the important things about this technique, we have the next photo at our right with the short axis, and here we see we see that the right bundle is in the right side, but the left bundle and the left fascicles are in the left side of the septum, of the interventricular septum, and with subendocardial localization. It means that they are deeper. That's why we try to reach this position. So this image is very important because that's make us understanding a lot of things during our implementation of leads. So that's all for this presentation. So here we will start with the first step. We try to make the implementation of pacing of left bundle branch area slightly easier. So we make some step to make more understanding of this technique. So the first step, we have to identify the area of interest. So as we know, the area of interest is after we are targeting the left bundle in the proximal part of the left bundle. So we have a lot of technique. The first technique that was used is his location. His location actually is less used. It needs the others tools and materials. So we will not talk about this one. And the second technique is contrast enhanced image guided. Actually is the most used and the easier one that we can for beginner or everyone to start this technique. And with the pacing QRS. So we will start with contrast enhanced image guide. So in this image on our left, we have the reference image that we should take during the operation. After injection of the contrast, we have the limit between the right atrium and the left and the right ventricle by the tricuspid annulus. So in the summit of this tricuspid annulus, we have our his bundle, and after that, the area, if we see in the right side, the area of interest is just 1 centimeter to 2 centimeter after the tricuspid in the direction to the apex of the right atrium. So here the area. This is the most important part, and sometimes we can have some posterior area targeting the left posterior fascicular for the implantation. This position is more stable and gives also good QRS weights at the end and synchronization. So after identifying the contrast of area, We can move to other slide. So here we have in RAO during implementation the view, and it's divided in green area and yellow area. So the green area is the area of the left bundle, where we can have reach the left bundle in her proximal part. So far it's yellow, so we will reach the left posterior. It will not be the left bundle branch area pacing.
Dr. John, before we go to the signals, Dr. John Kamel, do you want to comment on the fluoroscopic picture and how to choose the best site to reach the left bundle?
Yes, I'd like to comment. Yes, originally the conductive system basing was applied for His bundle basing. The original theory is to base the His. As we learned from the previous lecture, that basing the His need a high output because the His bundle is capsulated, and the stability at the His area just beneath the tricuspid valve is a matter. So the His bundle basing theory, which was originally very good, because of its drawback, it changed into a left bundle area basing. Here in the left bundle area basing, we go down by and anterior by about 1 centi or to 1.5 centi anteriorly and downward from the His bundle, as we can see in the image from at the left side. Here we can capturing the left bundle, and usually the basing threshold for left bundle is low, not as high as the His bundle. And also the stability in the lead in the left bundle area is much improved than the His bundle. So most now the conductive system basing apply left bundle, but sometimes we cannot capture the left bundle, and so there is other modality other than the left bundle. Here is if we go more anteriorly and downward, we can capture the fascicular left fascicular, either mostly left the posterior fascicle, and it's called fascicular basing. And it's also another modality for conductive system basing. So it's conductive system basing, we can capture the His, capture the left bundle, which is the best thing, and if we cannot capture the left bundle, we can go down and anterior to capture the fascicle. And even we could not capture the conductive system, we can capture the LV. So there's a theory called that left ventricular septal basing. Please mute Dr. Rania, mute. So this all modality. How to implant, how to make the lead go to the septum in the left bundle and the fascicle, we will show in advance in this presentation. So I would like to Dr. Fatima to continue its presentation.
Okay, so we are in the first step, or almost for identify the area of interest. So after the view, the angiography view that we did in RAO 30 degree, we introduced the lead with counterclockwise to this area that is in 1.5 to 2 centimeters from the tricuspid valve. In here, we will check our QRS morphology with pacing, with unipolar pacing. So the important things is to have a notched W pattern in V1, with lead 2 more positive than lead 3. And the most important things, AVL should be positive. We can make sometimes spacing to be sure that we are not in the RVOT, and this location will allow us to have perpendicular penetration in the septum that we will see in the other view. So this is the first step to identify the area.
Okay.
If you have something to add, Dr. John.
Yes. I'd like here when we introduce first the sheath that had a B-shaped curve for going to pass the tricuspid annulus and go to the right ventricular septum. This pre-shaped sheath is almost important to preserve its curve during implantation, because this sheath will help you to go to the septum. Originally, we use the dye, as Dr. Fatima says, dye inside the right ventricle to show where is the tricuspid valve and where is his location. But now, because of our experience in the conductive system basing, so we did not use a dye from the first to locate the tricuspid valve. We just pass the tricuspid valve by the sheath, by anti-clockwise. When you go for a clockwise rotation of the sheath first, you pass the tricuspid valve. Then you apply anti-clockwise. When you apply anti-clockwise rotation of the sheath, after it passes the tricuspid valve, it will go to the septum. It will go to the point of interest, to the septum. Immediately when the sheath hits the septum, we will saw such notched W pattern PVCs in V1. So after you go to the septum by the sheath, not even the lead, it will make some PVCs. These PVCs will have notched W pattern PVCs in V1. If you don't have such PVCs of left bundle PVCs, so you should re-annotate or redirect your sheath into the septum. After you have such PVCs by the sheath, then introduce your lead to the same area supported by the sheath. You just push the sheath slightly to maintain torque on the septum, to maintain push on the septum. Then introduce your lead inside the sheath and make about rotation 5 to 10 clockwise rotation of the lead inside the sheath. These will make the screw, which is located at the very distal of the lead, to penetrate such area of the septum. When you are penetrating, while you are penetrating the septum, the first penetration will also give a PVCs that have a left bundle with notched W-shaped pattern in V1. After 2 or 4 rotation of the lead, the PVCs will change its axis, will have a different pattern of PVCs called a QR pattern in V1. as well Dr. Fatima will explain later, this make you to see that you are penetrating good inside the septum, and a change of BVC's morphology. This is of importance issue when you are applying the rotation of the lead inside the septum. So we will continue by the next slide. We have here a different location of the lead, all these inside the septum. Number A and number B, you could see W-shaped BVCs in V1, while number C and number D do not have these W-shaped BVCs. So our best location is the mid-septal location. As we go forward, we use two imaging, is the RAO 30 degree, as we can see here in RAO. After we introduce our sheath and lead, first original we introduce in RAO view. Most of the implanter like to proceed by rotation by the LAO view, where they can see clearly how it is the lead is going inside the septum. And here we can use a contrast by the side weight of the sheath. The sheath have a side weight. We can do a contrast and see how we are deep inside the septum. So in RA view, as you can see, tricuspid valve is used as a reference point. Advance the sheath 1.5 or 2 centimeters from the tricuspid valve, and the catheter point between 1 and 2 o'clock. Change into the LOA view 30, confirm lead position, and the catheter point between 2 or 3 o'clock, and make the sheath definitely perpendicular to the septum. So, after checking QRS morphology, maintains sheath position to the septum. Usually use a clean and dry gloves when you are rotating the lead, because it's important to give your all power of rotation to rotate the lead. And most of the implanter, as we can see, go to the LAO 30 to see how they are penetrating the septum. After good penetration of the septum, the BVCs will have a right bundle pattern in lead V1 with QR morphology. After you get these BVCs or just pattern, you will stop rotation and inject a dye to see how it is far inside the septum, and you could base and see how is the morphology of the QRS complex at such a point. I will let Dr. Fatima to have to continue the presentation with the progression of the
after the three important steps. So the first step is to detect the area of interest. Donc keep the sheath in the same position, and the second step is to screw the lead inside the septal with using two view. We do using the RAO view and the LAO view to see if we are perpendicular. It means if we are in the position when we have the morphology of PVCs A and B. It means in the middle part of the septum. And this part of the septum is the part that we see in the anatomy, where we can have the left bundle, the pacing of the proximal part of the left bundle. So for this, after screwing, it means during the penetration of the lead inside inside the septums, we remember that the left bundle is in the left side and subendocardial. So we have some distance. So, and during this maneuver, we will check some information that are very important to see if we are in the good position or not. The first one is fixation beats, progression of QRS morphology with pacing, and dependence drop, current injury in depth of lead tip. So for the change of QRS morphology, first we check with pacing from the right side, this notched W pattern in V1. After that, this part, after the notched part will move up and towards the ends of the QRS to give R. And we have this pattern of right bundle block. That means that we are reaching the left bundle, the area of left bundle. So this is the first change that we will have after 1 to 2 turns of the leads. So here we have some pattern of QRS that we will have during penetration until we get to the left bundle. So, and we will see the change in the V1 and lead V1 and also in lead V6. Donc we see that we have, we will move from left, from the right to, we will see from the right to left. So we will have this negative part in V1 that will change to QR and when we reach the area of left bundle pacing. Dr. John,
here,
if you have something to add
I will,
this slide,
some explanation. If you get a QR pattern in V1, so definitely you have.
Dr. John, please move the slide up.
Okay. I will make it clear, because here we have a 3 pattern of capturing the left side of the septum. First is the left bundle area basing. We could capture the left bundle, and the clear clue for capturing the left bundle is the QR pattern in V1. If we could not obtain this clue, if we could obtain just RS pattern in V1 or just a Q wave without R, so we could not capture the left bundle, but we are capturing the left side of the septum, so it is called left ventricular septal basing. Okay, as we can see in number B location, we could not capture the left bundle. We just inside the left side of the septum. Here is, if we base at such area, we will get a narrow QRS complex, but not as narrow as the left bundle basing. Here is the difference between the A and B and C. In A, we could capture the left bundle with QR pattern in V1, and the QRS complex about 110, 100 millisecond. While in number B, which we could not capture the left bundle, but we captured the left side of the septum, so it is called left ventricular septal basing, will have another QRS complex, but about 130. And as we can see, the stimulus to the peak of the R wave will be delayed in V5 and V6, which is called peak to R wave in V5 or V6. And lastly, in number C, which we hear in deep septal basin or mid septal basin. We even did not capture the left side of the septum. We are in the middle of the septum. And here also, it will make a good threshold, but as you can see, it's a left bundle morphology. There is a notching in V1 or V2, a W-shaped pattern. So we did not even go to the left side of the septum. And here is the progression during a turn of the lead. We'll first get the left bundle, which is the deep septal, mid septal. Then after those 2 turn or 3 turn of the lead, we may get the left side of the septum, which is called left ventricular septal basin. If you could, it is good to go to base at such area, but if you get this clue, so continue to make another 2 or 3 turn of the lead to capture the left bundle, which is the original our plan to capture the left bundle. This is the difference between the 3 patterns: left bundle basin, left ventricular septal basin, mid septal basin. And here we could see clearly the fixation beat. In the first beat, BVCs is in V1 is W shape. The third beat is a Q with a small r, which denote mid septal or deep or left ventricular septal. Then finally, when you go to the left bundle, we will get BVCs with QR, big R in V1. Here is thing you could, when you are turning your lead, you always watch the screen of the ECG. You not only watch for fluoroscopy, you will watch for the ECG, because this thing make you clue you are going inside the septum very well. So then after you go to the left bundle, you will check your impedance. This is the second step. Here is impedance usually gradually rise as the lead penetrate to the septum. So starting from 200, 300, and as the lead reaches the left bundle, the impedance fall by about approximately 200 ohms. So the impedance usually start low. When you are penetrating to the septum, it start to rise up to 800 or 900 or even 1000. Then when you are capturing the left bundle, another drop, a drop of the impedance by about 200 or 300. This is good. The last drop of the impedance, it means that you are reaching subendocardial of the left ventricular septum. Here is you should stop turning your lead, because if you are turn another 2 or 3 turn of your lead, then a perforation will occur. Perforation to the left ventricular cavity. And here, how to detect perforation? By first fluoroscopy, second by impedance drop. The impedance will drop immediately about 600 or 700 ohms. So impedance value less than 500 ohm indicative of septal penetration, but sudden drop more than 300 or 400 ohms This all important because these may indicate that you just about to perforate the left ventricular septum. The depth of the lead is what's called, we have a QRS morphology. As we can see, these the 4 steps or the 4 grade of the depths of the ventricular lead. First of all, if you just capture the right ventricular septum, so here in V1 we'll see a QS pattern, just notched left bundle pattern. This is the right ventricular septum, and here in the image, it just the lead tip depth is 0 to 1 millimeter. If you could penetrate a 9 millimeter, so it is called deep septal basing. Deep septal basing, and here is V1 will give you a Q pattern in V1, but it's not notched. By making another 2 turn with penetration about 11 millimeter, you will get to the left ventricular septum. And if you advance more, another 210 will capture the left bundle. Sometime you could not capture the left bundle. You will go from mid-septal basing to left ventricular septal basing, and if you got more turn, so you will perforate. So it is not always to capture the left bundle, but even left ventricular septal basing is also good for synchronization of the left ventricle. I will let Dr. Fatima to continue by the depths of LV of lead tip.
Okay, thank you, Dr. John. So as we say about this fluent step during the progression of the lead inside the ventricular septum, so we have some signs that they are very important. As Dr. John says, we have fixation beat. So the appearance of QR, it means that we have to stop. It means that the risk of perforation is very high and we are near or inside the area of left bundle. And after that, we have the change of morphology, the change of width of the morphology in the V1 and V6, and also the distance between spike and the peak of R in V1 and V2. And all these criteria are very important. And we have also the impedance. So we check the pacing of the leads by unipolar. We use unipolar pacing from the tip and from the ring during this procedure. So when we are sure that we are in the good position and that we have all these criteria of QRS, of drop the impedance, and the distance between the shorten of the distance between the spike and the peak of R in V6, we will use this maneuver to be sure that we aren't outside It means in the left side of the ventricle. So we will pace the electrode from the tip and unipolar, and we will see if we are capturing. If there is no captures, it means that we are outside. It means that we are in the left side. That the lead is in the left cavity. So here we have to, it means that we make a perforation, and in this case, we have to remove the lead, not just to remove it and to leave it in the same place, but to remove it and to change and to check for another place. That's the first things. After that, if we will check during this unipolar pacing of the tip, the morphology, the QRS that Dr. John explained well before, so we will have all the criteria, and also we will see the threshold that will be low than 1.5, but almost the threshold can becomes more. It means more lower few minutes after, so we can check it and recheck it to be sure that the threshold go down on the time. So for the ring, so the question, when we have all these criteria, we will see if we still have some millimeters to penetrate the lead, or we should stop. So pacing and the tip is correct. The good capture, we have good criteria in ECG, and we have good impedance. And so everything is it. So the question is the ring. If the ring is inside the septums, or still in the right, still in the right side, in the right cavity. So here we will almost pace from the ring by unipolar, using unipolar. So 5 volts, if we have right bundle block from unipolar pacing from the ring of the electrode, it means that we are in the septum. If we have no capturing from with high output of voltage pacing, it means that we are far, like 1 to 2 millimeters far from the septum, so we can make some turn. It means screwing ladders 1 to 2 turn and check also. So this checking is very important, and we can repeat it from time to time. I think that's the last thing that we still have to be sure about our position. That the lead is inside the septum is the contrast. So we see that the contrast is very important, almost for beginning, as Dr. John said, that with experience we could not use it to check the area of interest. At the end, we use the contrast to see if the parts of the 2 electrodes that we have in the leads are inside the septums. And here in this view, an RAO view, 30 degree, we see that we have the contrast that we show the septums. It means that we show the septums, and that the lead is inside the septum. So we see the right part of the septums clearly with the contrast, and the lead is in the good position. So all the parameters are good. One thing that it is important to take on mind during all the operation, it means from the beginning to the end, is some risk of perforation. So the risk of perforations it means it can happen if we have like threshold in the tip more than 1 volt for some authors. It could be more than it means 2 or 2.5. The current of lesion. So the impedance, it means that the EMG that we should follow during penetration of the lead. If the detections is less than 5 millivolts, and in this case we will have the Q that Dr. John explained for the impedance. It means that we penetrate. The good windows for current lesion is between 10 and 5 millivolts. That is the good things that we should have. And almost the sudden drop. The value of there is a lot of discussion about the value of the impedance. For some authors, it's low than 400. Others, it's 500. But the most important things, and the things that have a lot of value, is the sudden drop more than 200 of impedance. So that is the sign of penetration. So if we have some depth, it's very important to change the position and not just to withdraw the lead and they keep it in the same positions. So so that's it. If you can say the last step to withdraw the sheet. So all the criteria are correct. We check the pacing all the time, and we are sure that the ECG in front of us is correct. So to withdraw the sheet is an important also step to not move the sheet. So we have we have to keep. It means that we can withdraw a little the sheath and keep just like 5 to 8 millimeters of the lead with U shape to test the stability of the lid during this time. And you can lay it like this and put the right atrium lid, and after see if there is no, it means no change of movement, no change of threshold during pacing, and and also the view and the angiography is almost say the same things. That means its fixation is very good. For some authors, we can make some, it means some screw or just pull it a little, but it could be sometimes could move the lid. So and we allow to slack before slitting the sheets. And after slitting the sheet, we will almost do the test in unipolar and bipolar configurations. And after that, all the criteria are correct, we will check the transition from our morphology with the label of our t-shirt, going from high output of the t-shirt to the low output. So here, when we are doing this maneuver, we are searching from the exact place of our lead. If with high output, we are the same morphology, and we are going to the low output, we will have some, we should have the same distance between the spike and the R, and the peak of the R wave and the V6. And sometimes the QRS can becomes more narrower with disappearance of like the D delta. It means that we are capturing the Hesse.
Okay, Fatima, many thanks for your presentation. This is well done presentation. I will summarize take-home message. First of all, identify the area of interest. Originally, we thought a dye will be beneficial for the beginner, but in the area of interest usually 1.5 centimeter anterior and below the Hesse. Either his localization, contrast injection, and the area of interest nowadays we just get by the QR's morphology of the BVCs generated by the sheath. Perpendicular sheath orientation to the septum, contrast injection after penetration is important. And number 3, know the depth of the lead tips in the septum by fixation beat the current lesion, the impedance, the base QR's morphology monitoring, and after that, withdraw your sheath. Before slitting the sheath, just draw it to test the stability of the lead, and after it is inside the right atrium, you can slit the sheath away and make your fixation to the subclavian region. And thank you so much for your presentation and your listening. Dr. Mervat. I guess Dr. Mervat is away now. Yeah.
I'm not away. I'm here.
Okay.
I'm beside Fatima.
Okay.
Thank you very much, Dr. John and Dr. Fatima, for very, very in-depth explanation, step by step. And the pitfalls, I would like to mention that perforation of the septum is not a big deal. You have to withdraw the lead, clean it up, and then reinsert it. Don't take it retracted 1 or 2 or 3 millimeter in the same part, because it can slip again and go into the left ventricle. There was a presentation before, I mean, in the case presentation about the lead being in the left ventricle from this site of perforation.